I'm Lynn Lindaman, and I approve this message. In orthopedics, anytime you're giving a talk, you must declare any conflicts and any financial situations so that there's no way you're benefiting from this. And in my case, the only conflicts I have are with my kids. And as far as the financial disclosures, there it is. This talk's going to be a little bit different than the other talks you've had, and actually different than any other talk I've ever given. You've had some great basic science talks, some great clinical science talks, and it may leave you with, how does this impact you personally? From the standpoint as a person with fibrous dysplasia, yeah, this definitely affected my life. And to try and recount to you how it affected me, how I adapted and accommodated to it, it'd be difficult to translate my experience 50 years ago into what you or your children are going through at this time. To a great extent, it did guide my entry into medicine for one reason or another. As a physician who treats FD, as Mike said, they wanted me to talk about FD from both sides of the knife. One thing I can unequivocally state, in orthopedics, it is better to give than receive. It does allow me to, probably more than any other surgeon, to understand how FD affects the person both physically and socially. I've experienced what these patients and you people are going through, and I've experienced the failures of these attempts. And that led me in medicine to, as with anything, to do as much as I can to be sure that no one else experiences these misadventures. The experience I've had pretty much has chronicled the evolution of our understanding of fibrous dysplasia. I've experienced the failures of the surgical treatments. I've seen the development of our understanding of the genetics and the physiology of fibrous dysplasia and how this plays into the biomechanics of bone structure itself. And I wanted to use that experience to help sort of continue the understanding of the disease and the treatment. But I was always much more clinically based. When I was prior to getting into medicine, I taught school and I coached and everything. And I've always been one who's much more out there teaching and doing rather than researching and studying. And so I left that up to Dr. Collins and his crew, and I get much more enjoyment out of actually taking care of patients. And the one thing I will say, looking back on my 55 years of management of fibrous dysplasia, I really think at every turn I was getting cutting-edge, state-of-the-art care. And so going through this will give you a little bit of a history of the development of the care. And just because of the way medicine is, this being a bit of an unusual disorder, you still see variations of this still being practiced. So I want to take you on a little journey of how I got from this in 1959. Right now, Bob Stanton's not here. You'll look at that, and my God, that'd be real easy to handle. Slam a rod in there, get him out of bed the next day, turn him loose. Okay? How I got to that, and eventually to that. Now, I was diagnosed in 1959 because we lived about an hour and a half from the Mayo Clinic. I was able to get state-of-the-art care, which at that time was aggressive curettage and actually allograft grafting, bone bank grafting. In spite of, that was when I first x-rays in 59. In spite of that, you can see in 60 and 62, the disease got worse.
That was after grafting?
That is after grafting. Yes.
And
And is
how old
it?
you were at that time?
Yes, I was born in 1950. So I was discovered when I was 8. That was at 9 and 11. Born late 50. Okay? 9 and 11. And in spite of the grafting, now we realize because of the grafting, the disease got worse. But again, back at that time, it was, this is bad bone. And as an orthopedist still, an orthopedist back then, if you want to get rid of the bad bone, get good bone in there. And those of you who were here yesterday, we still have that instinct and still have that image. And finally, in 1963, I underwent onlay allografts from my father. They took the fibula out of each leg, split them like barrel staves, wrapped it around, and one interesting thing, let's see if my mousey works here. There we go. In 1963, an intramedullary rod. Okay, quite aggressive at that time. I was hoping, actually, I was just 12 at that time. The orthopedist in the Mayo Clinic and all the pediatric orthopedists said they would never rod anyone under 10. They got thinking, oh my God, ducked back through, I was 12. Couldn't catch him on it. But anyhow, the important thing about this type of a rod is that, and you can see they actually did straighten the femur. Bone, ADD moment here, look at squirrel. Bone is like concrete, okay? And it's really strong. Where's a quick piece of chalk here? Okay. It's real strong this way when you load it axially, compression. It is not strong side to side or in twisting. So the orthopedist up there, understanding that, realign that bone. The purpose of the rod is mainly to hold it aligned while it heals. And he bone grafted it extensively. And sure enough, in a year later, or just 2 years later, you can see that the bone graft has fully incorporated. Not as normal bone, but as fibrous dysplasia. The fibrous dysplasia now has expanded right out into that bone graft. The disease here was getting worse, and the rod was removed because it wasn't providing any function whatsoever. The next intervention, 3 years later, this is a, where's my mouse? This is a shepherd's crook.
So
It was
3
just
years.
3 years. That is a shepherd's crook. Okay. Now I purposely have saved this with the identifying information up on top because I think that is a copyrighted photo from one of Uli and Darlene, the pathologists at the Mayo Clinic. I've seen that in at least one of their books that they want to claim violating of copyright laws. I got the original glossy. That is my number. That is me. It's mine. That's a shepherd's crook. Now, again, rather than just curating and grafting, as a lot of orthopedists might at that time, they actually tried to straighten it again. Here you see a couple of months later, they have straightened it, trying to get more linear weight bearing with a state-of-the-art, quite massive plate at that time. But again, we talked yesterday a little bit about cantilevers. For those who aren't mechanically or physically oriented, physically oriented, the body, this mouse and I are not having a good time. There we go. The body weight is coming down through here. That is like jumping on the end of a diving board. where it's going to try and either bend through the neck, or if this is rigid enough, it'll pop the plate off to the side. That's going to be the mechanics of it. That's why it is structurally inefficient. In 1967, that was the best that there was. And, well, he got it somewhat straighter. If you look way over here, with this shepherd's crook, there's a tremendous bending force through here. And there's a little feature of bone that when bone is placed under tension, it weakens and dissolves. So this bone here is going to be weakening, dissolving, cracking more, which will make it bend more, which will make it weaker, which will make it crack more, which will make it bend more, and down you go. So to try and stop that, they straightened it and reinforced, again, in 67, really aggressive, state-of-the-art, biomechanically, basically sound care. It just doesn't get any better. And as we see happening over here, a year later, actually less than a year later, stress fracture. Simply walking that road because of the mechanics, the bone trying to bend, and all the stress concentrating at that point. It did go on to heal, but with the bone more bent. More bent, it's going to be weaker here, more prone to breaking, etc., etc. Now, this is in 72, which I think was 4 years later. We can see that not only while the fracture down here has healed, you can't see it on this copy of the x-ray, but while you had that support there, the head has continued to bend off. Now, in spite of some of the common parlance, oh, the bone, the metal is cutting through the bone, the metal's staying put. It's the bone that's literally bending off of the metal. And we're getting pain. Yeah, this is 5 years post-op. Pain here that's literally cut through the femoral head. And so, again, this is phenomenal straightening. He really outdid himself. He's got this, if you remember what Dr. Stanton was talking about yesterday, the neck shaft angle. Here's the neck of the femur, here, and here's the shaft. He's really got that thing cranked on up. A big plate in there. The distance, the mechanical distance between where the weight is and the shaft of the bone is now cut way down. Over here, the weight is here. The line of bone is way out here. He's really cut that angle down. Okay, did great. Wonderful, except it's a plate. And again, in 72, that's all we have. In 75, the entire femur's not protected. You see this has gone on to heal up here quite nicely, but with multiple other fractures, the entire femur is now broken. Here is a fragment of one of the screws from the earlier plate that had broken simply because of the stresses on the plate. Here was a fracture at the bottom of the old plate, fracture at the bottom of the new plate, another intervening fracture just because of poor mechanics. So in 1975, this is probably the first evolution of supporting the whole bone. Multiple osteotomies. And in spite of, it's looking like there are a lot of cysts here in the chest. I had it, you can see them. The intraoperative photo does show the top. It's sort of a real thick, rubbery, vanilla pudding type substance in there. And it's aligned. He has protection in the feet. He has, again, brought the leg back into a closer alignment between the femoral head and the shaft. Got this angle better. The femoral neck is protected, and he's got the shaft aligned and protected all the way down. This is Zickel nail at that time, which is state-of-the-art. One problem is that with the Zickel nail, it just sits inside the bone. And so that bone can spin and twist around that nail. And bone doesn't like twisting, shearing stress. So it's real prone to fracture with any twisting sort of motion. The other little error was a technical error that he tried to correct but couldn't, and that was the fact that this blade here actually pokes out the femoral neck. But I'm trying to get it right in the center. Well, we had, this is I think the 8th operation in since 1960 in 15 years, or about every other year. Over the next 14 years, nothing. Merely getting it aligned, getting the bone supported. We had been able to avoid any other major fractures, any bending, any bowing for 14 years. Now, due to a slip and fall, that little blade poking out the femoral neck broke the femoral neck. It was at this time that we started to get the newer types of hardware from the trauma end of things, that in addition to having screws, this time screws up the femoral neck, not just a blade pounded up there. The advantage is, with that solid blade on that sickle nail, if the femoral head and neck collapsed and shortened as it healed, the blade was going to stay put. The blade stays there, the femoral head shortens, and the blade ends up sticking out into the acetabulum. Okay, not good. These are screws that are fixed into the femoral head. If it shortens, they just back out here. The other advantage is that it's what we call an interlocking nail. There's a screw that goes through down at the bottom, one or more, they have one in here, so that you got the rod now holding the bone aligned, and the bone is held to the rod so the bone can't twist. Much more fully protected. Also at this time, and there was grafting done at this time, that was still the accepted mode, though at about this time, the University of Michigan released their study showing that bone grafting doesn't work. Up until that time, and even past that, the accepted standard of care was you scrape it all out, get rid of all the bad bone, you pack it with bone graft, almost always cures. Well, maybe you didn't quite, you're the outlier, okay? Until we realized nobody did. And then, with the advent of the, we started to understand why in the upcoming years. And that was growth different from the mosaic of cells. So here it is in '89. No further problems, for the most part. Skiing, playing softball, doing all sorts of typical recreational type of athletics. Until 2005, when, again, almost 14, 15 years, again, of progress, healing, that old man. If you notice, if you see where the screws are here, you see where they are here, things have relentlessly settled and shortened. And fibrous dysplasia relentlessly aggresses on it. You cannot get rid of it. But we slowed it down from a surgery every other year to one every 14 years. And if you look distal, people would say, oh, the rod's migrated. No, the rod stayed put. Here it was in '89. Here now see. Here it was in '89. You look where the screw is and the rod is. The rod now has migrated. That is, it's actually stayed put, but the bone has bent and deformed, getting more bowed, so that this is now impinging out here, and pain starting to come back. Also, I had a persistent 3-centimeter limb length discrepancy, and so went on to the next advance in medical care, and that was just a lengthening and a rerodding. And we got to, you can see with fibrous dysplasia, we were able to get a good amount of length, fixation of the entire bone, almost. Still got a little problem up here with the femoral neck, not protected up into the femoral head. You got a little support here, but nothing really up into the femoral head. You look at the hip joint, seems to be getting a little bit thin. And being a good orthopedist, I knew that eventually I was probably going to need a total hip, and decided that studying around, the only real studies out of the Mayo Clinic, which showed that the average they failed about in 3 years. And at the age of 55, at that time, to fail in 3 years, there is no salvage. It's not looking good. We had a meeting out here with Ernesto Ippolito from Rome and Shlomo Weintraub from Tel Aviv. And at one of the coffee breaks, I cornered them and said, "Do you guys do total hips and fibrous dysplasia?" "Oh, yeah, sure we do." Yeah. How did they do? Not so well. So, with that, I decided the only way I'm going to get a total hip is when they drag me back kicking and screaming. Which became prophetic. If you look over the next about 8 years, there's a definite change from here to where here's sort of the femoral head. And because there's no protection up in this area, it literally has migrated superior, and the femoral head is just sliding right on off. The only thing that wasn't prophetic about this was I couldn't kick. Okay, but I made up for it in screaming. So a year ago, I underwent a total hip, and from having intractable, when my wife dragged me into the ER on July 4th at 4 in the morning, they asked me on a 1 to 10 scale of pain, what was my pain, and having had numerous fractures and operations, figuring post-operative pain is a 10, I said this is on a totally new scale. But afterwards, I felt like I'd been snuck up on from behind with a midget with a samurai sword. I felt all flashed up. But the first thing that I noticed was pain was gone. Unbelievable. And the pain has stayed gone for the most part. So this is the answer, right? What's going to happen with the mouse down here? Unprotected. That's unprotected because this was the biggest, longest prosthesis you could find, and
they could make one.
So to get a custom thing, I wasn't going to push him for it. He said I could get this, and I really couldn't wait for a custom prosthesis. It took me 6 weeks. He was in back phone lines, calling in favors to get in. It 6 weeks, but 6 weeks was the longest year of my life.
Where was this?
At Iowa City. Okay. And he knew what he was getting into. And he usually, even for me, who I don't do a bazillion with total hips, I can do a total hip in an hour 15 minutes. These guys with assembly lines can get through them in about 45 minutes. This took him 5 hours. So he did not have a fun time.
Lateral or anterior?
A posterior lateral. Okay. And he knew what he was getting into. He comes in the next morning and says, "Lynn, how you doing?" And I go, "Nick, wrong question." "What is the question?" "How do you do?" Sort of better today. But he did bone graft up into the acetabulum up there. I cautioned him that the history of bone graft and fibrous dysplasia is not good. And he knew I was an orthopedist. And as an orthopedist, I'm going to shoot my mouth off, tell him how I would do it. And I said, the one rule I want is I will do exactly whatever you say. You can do whatever you want, but I get to shoot my mouth off. And you have to listen. So we had a good agreement. And he did bone graft. So far, it looks like it seems to be staying. And from what the research now is a decrepit old man of 63, it may actually do fairly well. So we'll know in several years. I'm 1 year out. I said I got to get 4 more years before I consider this as a win. At this point, as far as taking you through the history and stuff, it'll keep you informed on this deal. But as far as from both sides of the knife, I said, counter to your thing up there. Another Dewey's a bird thing. Yeah, from Dewey's bird. I I've seen the evolution of it. It is still going on out there because fibrous dysplasia is a bit of an unusual thing, and up until recently, the still taught idea was you get rid of the bad bone, bring in good bone. What those of us who have listened to Mike and his friends realize you can't bring in good bone. With tumors, when you take out the tumor, there's good bone around it if you scrape back far enough. So when you bone graft, it brings in the good bone. With fibrous dysplasia, there is not good bone. It's a mixture. So you graft, it brings in not only a mixture bone, but actually, because the dysplastic cells have a growth advantage, it brings in more dysplastic cells, and things just get worse. My comment, when giving it more of a science talk, is bone grafting doesn't cure fibrous dysplasia, it just pisses it off. Okay. So, trying to get back on time, we're going to make up a little time here. Any questions?
So, what do you suggest when there is a big fibrous dysplasia lesion and the surgeon goes in to correct the deformity and install some hardware? Should you just leave the lesion as is?
Yeah.
Don't take it out at all. Don't put anything.
What Dr. Stanton says is there are true cystic lesions. Okay. Now I've not seen a lot of them. We may be dealing with a different mix down there. Even actually a lot longer than I have. But when you bone graft fibrous dysplasia, it just brings in bad bone. But bad bone is better than no bone. If it's a true cyst, go ahead and graft it. Okay.
There's a pocket.
If there's a true fluid-filled pocket. But most of them aren't. They'll look like a fluid-filled thing on the x-ray, but it's really fibrous and it's solid. So, looking at my initial x-ray in '59, that'd be great for rotting. Actually, at that amount of deformity, my approach would have been to heed the old admonition of don't just do something, stand there. Leave it alone, okay? Especially when you're dealing, as Dr. Stanton said, with upper extremity things where you're not worried about deformity or weight bearing, leave them alone. I have a guy who brought his daughter in to see me for leg things, something about her, and on the family history, it was fibrous dysplasia. And I go, really? Well, who? He goes, well, I got this spot in his arm. He's due to go back in a couple of months for the chairman of the department, an orthopedic oncologist, to graft him for the 4th time. And I said, Dan, the first 3 didn't take. Connect the dots. It's not going to work. And he sent me the x-ray. You can just see it getting bigger and bigger and bigger. So, again, those things, you leave them alone. If you, like with concrete, if it's poured concrete, you reinforce it with rebar. Steel with steel. Okay? I'll get you back up on time.
We're going to, we hold that question